somewhere early this month, the World Health Organization and the Africa CDC declared monkeypox as a global public health emergency. And I think since then, there have been a lot of, inquiries. Some have been asking questions. Is this going to be a COVID-like pandemic? What is even monkeypox? So I think on this one-on-one, we are going to have an in-depth discussion about Mpox. I think we've been forbidden to call it monkeypox.
Yes.
So,
not the monkey that has it.
Yeah. So for the start, on one-on-one, I'm not going to introduce the guests. So I'll let the guests briefly introduce themselves. So let me start with Dr. John. Briefly, give us a bit of your background. Who is Dr. John?
Okay, thank you very much. My name is Dr. John Oladejo. I'm Director, Special Duty, Nigeria Center for Disease Control. I'm formerly Director of Health Emergency Preparedness and Response. So I've been incident manager for so many infectious diseases. The last one was COVID-19, where I have to be the head of the operation team, as well as the incident manager for more than 6 months, especially when we didn't even know what we were dealing with. But at the end of the day, we were able to combat the disease. So, have been involved in the establishment of public health emergency operation centers in all the 36 states of the Federation. After I finished my fellowship at the US Center for Disease Control in 2017, so we started, and during COVID-19, we were able to establish that. So we have been doing a lot of work in terms of public health policy, in terms of investigation of diseases and interventions of infectious diseases or outbreak, across the country. Thank you very much.
Yeah, thank you very much. So over to you, Professor Ashok.
Good afternoon, good morning, or good evening, wherever you are. And I am Ashok Rattan. I'm a medical microbiologist by profession. I have served in the academics, teaching microbiology in All India Institute of Medical Sciences. Then I did a little bit of research looking for new molecules. Then I went over to public health. I was with the WHO in the Caribbean and looking after 21 English-speaking Caribbean countries based in Trinidad. And now I'm into the diagnostic field. I've worked in various diagnostic chains. Nowadays, I'm chairman of medical committee and quality for Redcliff Labs, which has a chain of about 70 diagnostic labs in India. So that's where we are.
Okay, thank you very much. I think from the brief description of our guest, our audience would definitely give a thumb up that we have experts who can, deal with Mpox. So let me start with Prof. Ashok. Let us look at the evolution of, Mpox, since now we've been asked to, call it Mpox. So can you go through with us the evolutionary trend or dynamics of Mpox?
Mpox came into recognition in 1958 when monkeys imported from Singapore suffered from, and they were in Copenhagen, they suffered from clinical symptoms of pox. This was then decided. Then it was named. That is why it was named as Mpox. It was named as monkeypox. There was no human case at that time, and it was 1970 that the first case of human transmission was found. So that means it becomes, it is a DNA virus, is double-stranded, is brick-shaped, so it belongs to the pox family. Now, there appears to be man-to-man transmission, which is now why we are worried, but there is also animal to man transmission. In this, the transmission, the evolution has been that for many years it was localized to DRC or neighboring countries. And it was so since 1970, sporadic cases were coming. They will spill over, but the first spillover occurred in 2022 when cases were discovered in groups of persons who are known as MSM, men who have sex with men. And subsequently, it was noticed that this was, so 2 clades have been identified, that it's been labeled as Mpox because the WHO had taken the decision that we should not name any disease which will stigmatize the animals, the place, or any country. So that nowadays, that is what this started with SARS-CoV-2, where the disease was known as COVID rather than any of other name. And similarly, monkeypox have been now changed into Mpox. It was this was in November 2022. Though this the 2022 epidemic has involved about 100,000 cases in about 100 different countries, but that was by a clade which is supposed to be less pathogenic. This present outbreak, which was notified on the 14th of August, is from clade 1B, which is which has heterosexual transmission. This is in the animal experiments. 1A was more pathogenic, more lethal than clade 2, and the transmission from human to human is more. It appears that in pox viruses, as the virus localizes its range of infection, it becomes more lethal. And that had happened with smallpox. And the fear is same kind of evolution might occur with Mpox.
Okay, thank you very much. So, Dr. John, now looking at the evolutionary trend, let's talk about the numbers. You know, with the layman, yeah, the layman is always interested in the numbers.
Yes.
But if I'm correct, Professor Ashok gave us a history dating back in 1970.
Yes.
But let's look at it starting from July 2022 or maybe July 2020 to present day. If we can have a number.
Yes, from in Nigeria, we have 2,123 suspected cases. And then out of this, we were able to confirm 762. And we have only 7 confirmed deaths. So the case fatality rate at that time was 0.9. And this actually occurred in 34 states plus FCT. And when you look at the number of local governments affected, we have about 238 out of the 774. That is for 2022. But in 2023, the number of suspected cases was 1,182, and with 98 confirmed, and only 2 deaths. And the case fatality rate was 2.0, and this occurred in 25 states plus FCT. When we look at the local governments involved, about 65 local governments were involved. But in 2024, as we are now, we have actually recorded 802 suspected cases this year alone, with 40 confirmed deaths. And then there was no 40 confirmed cases, but there was no death. You know, the professor was telling us that you know, it's not that we have a lot of death like COVID-19 and so on. And that's the reason why we cannot call it a pandemic as such. So the case fatality rate was 0, and then we have it in about 19 states plus FCT. So the number of local government affected is 30 as we speak now. Mm-hmm. That is the cases and deaths from 2022 to date.
Mm-hmm. Okay, so Professor Ashok, I think I want you to come in. What was the numbers that led the WHO to declare it as a public health emergency?
I think it is the trend. When they initially, as you know, the first time they declared as a public health emergency was in 2022, where they noticed that instead of being localized only into DRC, the cases were spreading and more to different countries in Africa, and then also, then they came out to UK, to USA, to Singapore, to other places. And of course, as they said, about 100,000 cases belonging to 2B, which was, but one of the features was that it was restricted to mostly persons who had MSM. This one started somewhere in November, when they noticed that in a mining town, Kimbet, in DRC, there were a number of cases in sex workers, and in the 2022 outbreak, there would be, say, more than 90% were male persons involved were males. In case of this present outbreak, 2024 outbreak, they found that the persons were equally males and females, and the death was more. The transmission from male to male was more. When one case was reported, first, of course, was from DRC. It started spreading to neighboring countries in Africa itself. And as I think last count, 13 countries have been involved in Africa. Then when the first case was detected in Sweden, that is the time when they decided that this is more lethal. Then the next generation sequencing had indicated that this belongs to a new clade 1B. So 1A is normally from animals to children, which is still going on. 1B is now heterosexual, while clade 2B is MSM. So there are three epidemiological types of outbreaks occurring. And this one, which is 1B, which is heterosexual, is more transmissible between humans, and it is heterosexual in nature. And in last count, 5 different countries outside Africa, namely Pakistan, Thailand, Philippines, Australia, and Sweden, have reported Mpox cases. So it is spreading, but of course we know that the spread is through close contact. It can also spread through respiratory route, but it is not as infectious as COVID. At the same time, sometimes it reminds me of the situation we were in when HIV was first discovered. And luckily, this time we have vaccines available. There are cross-protection. Smallpox vaccination has cross-protection against Mpox. And most of us who are in the older generation, we have had vaccination with smallpox vaccination, but that stopped at 1980. So it's been more than 44 years since that happened. So our even the older persons, their immunity would have waned. But they have had second and third generation vaccine, and WHO has recently obtained $135 million to purchase 2 million doses of the vaccine and make it available for high-risk groups.
Okay. So I think from this narration, what we can, conclude is there are different modes of transmission. And one of it is heterosexual transmission. And so when we look at the dynamics, let's say in Africa, what are the predominant mode of transmission? Then maybe we take, or maybe like India also, and have a look. Yeah, Professor Ashok.
See, as I said, there are three routes of transmission. Mm-hmm. In children, it is through catching of small animals and then playing with it or eating them. Mm-hmm. That is one route of transmission. The second one was 2022 was MSM transmission, where males were mostly targeted. And this one is heterosexual. So this transmission will also be through close contact, including sexual contact. But here, males are equally affected and females are equally affected. So since this is more transmissible, since this is more lethal, the fear was that here, if we are not geared up fast, this would go out of hand.
Okay. So let me come to Dr. John. Okay. I think from the narration of Professor Ashok, we have two clades that are, in the system now. And I think the severity of the disease that manifests, is sometimes associated with the clades.
Yes.
So what are the differences between the disease severity between clade A, 1A, and clade 1B?
Okay. Actually, in our old system, I think what we have was clade 1B, and is associated with a special group. We call them a special group. This is MSM, and it's very, very, very severe, and very, very contagious among them. But for the 1A, which is among the children, it was not as pronounced as those one that we find in clade 1B, which is the special group I've just mentioned. So we now ensure that we make sure we work on that particular area. And the first thing we did was to activate EOC, Emergency Operation Center, and then we give it a level 2. So level 2 shows that although it's in different states, I told you the number of states we have now in Nigeria, but it's not as serious as Lassa fever. It's not as serious as COVID-19. So we place it on level 2.
I think in your the last submission, you did mention about pregnant women. And during the Zika outbreak, I think in the 2000s, one of the effects that we saw was newborn babies were having this small, head, which was associated with Zika infection. So is there any study or any data that outlines any kind of effect on pregnancy with regard to Mpox? Yeah, Professor Ashok.
Not that I have seen. The only study that I've seen is the data is from DRC, and they say that there's been no death of pregnant women, but stillbirth has occurred. So that would suggest that because see, the previous 2022 was MSM, so there was no pregnancy involved. 2014, 2024 is now heterosexual. So I guess more data will come out as time passes, because it was only in November that they first started talking about clade 1B and being heterosexual. But yes, they have mentioned that stillbirths have occurred, and but they have not mentioned that pregnant women die or they are increased risk of death.
Okay.
And of
so
course,
I think
in India, there's no case of Mpox at the moment. The last case we had was of the previous, this was in March. I think they have in total, they have 30 confirmed cases, and all of them recovered.
Okay. I think this may be an area for exploration. Maybe AHRO and Nigeria CDC can come out with some kind of project to have a proper look. What is the actual effect of Mpox on pregnancy and so on and so forth? And I think Prof Ashok is quite a dynamic person, so he may be involved in that potential project. So, Dr. John, I think somewhere last week, I read through a paper in which stated that there were 3 new cases of Mpox in Nigeria.
Yes.
So now what is, I think you've narrated a lot of project or interventions that the Nigerian CDC is coming up with here.
Yes.
So what has the Nigerian CDC put in place in case Mpox, escalates? For example, we know when the West Africa Ebola outbreak came out, some of us were taken by surprise with the way it kept escalating. But then one of the issues was the infrastructure or the readiness was not there. So what is the Nigerian CDC putting in place in case things get out of hand?
Okay, thank you very much, moderator. The first thing I told you was we developed incident action plan, and then we actually leveraging on COVID-19, lesson learned from COVID-19. When we started COVID-19, there wasn't anything like a laboratory. Even at that time, we have only 3, but I'm telling you now that we have about 140 laboratory.
Okay.
And all these laboratory have been actually, strengthened by the federal government. So we have people that have been trained that when they see any of these cases, they will just take the sample, go to any of these laboratory and be able to confirm. And immediately this is confirmed, so we have already trained the clinicians who will now take over the treatments and ensuring that we use IPC as our bedrock. So government too is actually procuring medical consumables and materials, and they are distributing it to all the centers where these cases may be found, where people who have these rashes can equally go and take some treatment. So these are the things NCDC actually is putting into place. And as we are talking now, we are still training our health workers across across the country. During COVID-19, we actually trained more than 50,000 health workers on the IPC, and that was the reason why there was a drastic reduction in the number of cases among health workers. So we don't take that one for granted. So we are still doing that to ensure that at least our health workers are not, infected as they are treating the patient. So, and we are equally having meetings with all our stakeholders. You will recall that our Director General just had a meeting with USCDC as well as the WHO, where WHO now promised that they're going to give us 10,000 doses, and our sister agency, National Primary Care Development Agencies, will be taking care of that to ensure that the actual contact, the special group are actually vaccinated. So these are some of the things we are actually doing. And as we're doing that, our risk communication experts, they are engaging the community. There is a lot of awareness going on now at the community level, a lot of engagement, a lot of involving all our philanthropists, all our traditional rulers, so that they will know what is actually happening and they'll be able to inform their subjects. So these are the things we are actually working on. Over.
Okay. So, Professor, can you have any input when you take India into consideration?
In India, what has happened is that the Director General of Health Services, he has taken charge, and he is also the Director of NCDC. So he has then one decision they have taken is that they have activated persons on all entry, because Mpox is not indigenous to India. It hasn't come in yet. So all entry ports, whether it's airports, land ports, or seaports, they have been activated that they will screen persons for fever. Then they have identified hospitals, and they kept aside beds. In that hospital, those hospitals which have been identified, they have also made the labs have PCR reagents supplied by WHO. So there are 32 labs which have been activated in every big city. They have some places available. Then they have had information available to everybody about what are the routes of transmission and what to avoid and how to go about it. At this moment, of course, as you know, India pharma industry is very active, and there is a drug available which in animal studies have shown good efficacy. They feel that once it is required, then the synthesis and the APIs, the active pharmaceutical ingredients, are easily available. They can assemble teicoviramate without too much trouble.
So we were able to mobilize all the agencies that are involved, the Ministry of Health, the Ministry of Education, the Ministry of Information, so that we be able to really look at the IAP, which is Incident Action Plan, and then be able to go into treatment as well as into RCC, that is risk communication in that particular group. But we don't start in those groups alone. We equally go to other places because we need to do what we call active surveillance. This is the right time for us to really go into the grassroots level and then go to the community, engaging the community, telling them exactly what they're expected to do to avoid close contact with anyone that have the symptoms of rashes or skin lesion. And then we equally inform them that anytime they should always practice good hygiene by regularly washing their hands with soap and water, using alcohol-based hand sanitizer. Then, in most of the hospitals, they don't really practice IPC. So we now went out of our way to even go into all these hospitals that we know most of the people that have these rashes will go, to really, give them protective wears like gloves and masks. And we inform them that anytime they are caring for any suspected cases, they have to make sure that they wear this protective gear. They should avoid contact with animals that have any that can harbor any virus, such as rodents, primates, especially in area where Mpox is known to occur. So we always making sure that we get all the clusters, and then we now institute interventions in those clusters. Then we ensure that meat is thoroughly cooked before consumption, and we equally train our health workers to go into the community and engage the community elders, the emirs, the heads of clans, and so on and so forth. And then we equally tell them that they should be vigilant for patients presenting with fever, rash, and other Mpox, especially if they have a history of travels to the affected or contact or any area where we have such a transmission. So these are the area where we have to curb the transmission, we have to interrupt the transmission, we have to ensure that cases are treated, symptomatically. The WHO has actually, promised to give us 10,000 doses of the vaccines, and these doses will be judiciously utilized in the people with special cases, which I've already mentioned, to ensure that we actually interrupt and stop the spread of the disease. Over.
Okay, thanks. So, Professor, do you have any contribution to add on the?
I think it is, so the first thing is to increase awareness so that people are aware. And then what India has done is they have identified 32 labs where material for PCR has been made available. But I think what is required is a point of care antigen detection, because once the rash is there and the diagnosis is to be made by taking sample from the rash, then it is infectious and it will remain infectious till the crust forms. So that means for 21 days, the person is infectious. So that would make sure that it spreads in crowded places. It's not possible to keep people isolated for 21 days or so. So if the diagnosis can be made quickly during the febrile stage before the rash appears, then I think, and then that person is isolated, that would be better, rather than the person moving to the hospital to get the test done in the hospital from the rash. That would make sure that it spreads in the community. So we need to quickly hurry up with the point of care testing using, because 1 week before the rash appears, during the stage of fever, there is viremia. So it should be possible to detect the viremia before the rash appears.
Okay.
And of course,
Sorry,
contact trace. Of course, we need to strengthen our contact tracing. And as the vaccines are going to be made available, and the contacts should be vaccinated, healthcare workers should be vaccinated, so that the high-risk groups are covered as more and more vaccines get available. I think the manufacturers are saying they can make 2 million doses in a year itself. So it's possible that everybody need not get vaccinated. Everybody needs to be aware. Everybody needs to do hygiene. Everybody needs to take contact precautions. But those who are at high risk, they should have vaccination.
Okay. So I think the last comment came with something that came to mind, high risk. So maybe let's take in India, and maybe Dr. John can also later come in, in Nigeria. So what are some of the if any, risk factors that are associated with the transmission dynamics of Mpox?
Risk transmission is in close contact with a known case of Mpox. Then the risk transmit. So the susceptibility of the person. If a person is immunocompromised, then also there's more risk. If a person is pregnant, then there's more risk to the baby, to the unborn child, than to the mother. But those are the other increased risk. So those persons need, and of course, healthcare workers. And I think in DRC, they said even sex workers are at increased risk because that's where the transmission is occurring.
Okay, okay. So, Dr. John, any addition?
Yes, Prof, I've actually said it all. You know, most of the time you see that transmissions among the special group, the MSM. We call them special group because we don't want to really expose them. So, you know, most of the time is sexually transmitted, and these people they really need a lot of engagements, a lot of risk communication engagement, because they don't care. So you will need to really get them to be involved in whatever we're doing. And then we need to develop and distribute communication materials and send it to them. We need to issue public advisories on Mpox and let them have it, even at the grassroots level. And then you see those compromised, those people living with HIV/AIDS too, we have it among them. And those people that are taking therapy, you know, cancer therapy, you know, because they are immunocompressed. So this set of people, we have it as dynamic transmissions among them. So we really need to really develop a special, IAP for them and then follow it up. So we need to conduct press conference, which we have done in Nigeria, and then review and finalize communication strategies for Mpox, because each disease has its own strategic way of communicating with the grassroots level. So these are the things that I believe we really need to do. Apart from the fact that we have trained clinicians on case identification and management, we equally established a community of practice for clinicians just to share their experiences, and then we equally quantified and forecasted essential response commodities for patient management. Apart from all this which we have done, we still need to do more, you know, in terms of ensuring that the special group are really reached out to and they are involved in the intervention strategy. So we are still doing that to ensure that at least our health workers are not, you know, infected as they are treating the patient. So, and we are equally having meetings with all our stakeholders. You will recall that our Director General just had a meeting with USCDC as well as WHO, where WHO now promised that they're going to give us 10,000 doses, and our sister agency, National Primary Care Development Agencies, will be taking care of that to ensure that the actual contact, the special group are actually vaccinated. So these are some of the things we are actually doing. And as we're doing that, our risk communication experts, they are engaging the community. There is a lot of awareness going on now at the community level, a lot of engagement, a lot of involving all our philanthropists, all our traditional rulers, so that they will know what is actually happening and they'll be able to inform their subjects. So these are the things we are actually working on. Over.
Okay. So, Professor, can you have any input when you take when you take India into consideration?
In India, what has happened is that the Director General of Health Services, he has taken charge, and he is also the director of NCDC. So he has then one decision they have taken is that they have activated persons on all entry, because Mpox is not indigenous to India. It hasn't come in yet. So all entry ports, whether it's airports, land ports, or seaports, they have been activated that they will screen persons for fever. Then they have identified hospitals, and they kept aside beds. In that hospital, those hospitals which have been identified, they have also made the labs have PCR reagents supplied by WHO. So there are 32 labs which have been activated in every big city. They have some places available. Then they have had information available to everybody about what are the routes of transmission and what to avoid and how to go about it. At this moment, of course, as you know, India pharma industry is very active, and there is a drug available which in animal studies have shown good efficacy. They feel that once it is required, then the synthesis and the APIs, the active pharmaceutical ingredients, are easily available. They can assemble teicoviramate without too much trouble. So it's possible that they can get the drug ready once it appears that it is required. At this moment, there is no stockage of teicoviramate or vaccines. So at this moment, so it is a non-specific activation of awareness and heightened awareness and heightened suspicion, and to look at everybody that's coming in to see whether there's a. But the weakness is that diagnosis will occur once rash has appeared. And once rash has appeared, that means then the person is infectious. Then to control it is going to be difficult. So that's what I think they're still looking for, a point of care testing. And people have been talking about CRISPR, but I have not seen that being available yet.
Yeah, I think CRISPR would have been a good technique, but I don't know how best it will be for point of care. Yeah. So, well, the next question, I think I'll first ask Professor Ashok for his opinion, then go to Dr. John. I think one of the lessons that COVID taught us was we have to always be ready. We have to prepare ourselves. But during COVID, we, I don't want to be too sentimental, but we have to, during COVID, you find out that when the vaccines were manufactured, the developed countries first vaccinated their people, they vaccinated their citizens. Then the next phase, they decided to hoard vaccines for future vaccination before even thinking of the developing countries. So what should we do, both as, I will always regard India as also a developing country. Maybe Ashok will challenge me on that. What should we do to prepare ourselves so that we are able to get access to vaccines or antiviral agents? Dr. John said that there's, the WHO has promised, is it 10 million?
No, 10,000.
Yeah, so you see, of a country of about 200 million people, that's Nigeria, 200 and plus, 10,000 vaccine is not
It's just a tip of the iceberg.
It cannot even take care of Abuja.
No, but they have mobilized $135 million. See, they have mobilized. They made a 6 months plan. They have mobilized $135 million, and there is promise that this is, and they promised to buy 2 million doses of the vaccine. So, of course, I think we understand that the vaccine is not for general use. It is only to be used in contacts, in healthcare workers, and in sex workers, and those at increased risk of infection. These are live attenuated vaccine. So we need to be careful that it should not be causing side effects to if we give it to all and sundry. So it needs to be harnessed well. But yes, COVID has taught us that we need to work together. And we also have understood that there are persons who are willing to work together, and there are others who only say we'll work together if you give us the money. So I guess this is the time for groups to make collaboration and joint ventures and start making local produce. Vaccine production is not that difficult. And of course, APIs, India makes APIs everywhere and makes it available. And so both, I think not every country, but every continent must try to become self-sufficient. In the meantime, we should have joint ventures so that we collaborate and help each other.
Thank you. So, Dr. John, any input?
Prof has said it all. To scale up access to vaccines and antiviral, so we need some strategies which I actually mentioned. Local vaccine development. African CDC should be leading on this. When we have Lassa fever, we make use of CEPI. CEPI is an organization that is actually assisting Nigeria to develop vaccine on Lassa fever. So vaccine development is very key. So we need to invest in vaccine research and development to ensure that effective vaccines are available for future outbreak. Then we need to have what they call global coordination and cooperations, which are very, very crucial in responding to outbreaks. So we need to establish strong partnership and network, as Prof has rightly mentioned, and we need to share information and resources. The point of entry is very, very key in this. We need to mount point of entry. What really helped us during COVID-19 was because we actually deployed more than 300,000 volunteers to all the point of entries in Nigeria, where they, we distribute questionnaires to people that are traveling from outside the country, and then they'll be able to examine them and then review them. And if they would be of danger to the community, they will have to isolate them at that point of entry until when they did the test. So the same thing for any infectious diseases, though we need to have what we call equitable distribution, ensure that vaccines and antiviral agents, especially in low and medium income country like Nigeria, to prevent unequal access and shortage. We rarely say that 10,000 doses of Mpox cannot do anything. But if we look at it critically, at least we can start from there. Look at the MSM, try to put them in clusters, and then ask our sister agents, National Primary Health Development Agent, to actually facilitate them. Then we need to look at the public awareness too. So we need to educate the public on the importance of vaccines and antiviral agents. Some people, they will say they don't want to take a vaccine, and there's nothing you can do about it. So Yaro, remember during the polio time, we have to develop different strategies to go to Kano, and ensuring that the Emir of Kano, buy our ideas so that other people will take. So there was always hesitancies in that. So there must public awareness. And then stockpiling and manufacturing we need to encourage that to ensure that we have availability of vaccines and antiviral during the outbreak. Then research and development, we need to really work on that, continuously funding research and development to improve existing vaccines and antiviral agents. And we continue to develop new ones. And that is the reason why we need to have a consortium of researchers where we have to, network, cooperate, and collaborate with them. So partnership is the key, and the African CDC should be on top of this, and all the other national public health institutes in Africa, they will support. I know that India, they did a lot of work during COVID-19. They were able to produce a lot of vaccines, and which was not even enough. So Africa should be able to do the same so that we're able to meet the market. There was a lot of demand during that period, and this was not good enough. So research and development is one of the things I will want us to take home, that we should really put all our hands on it. And then with this, we'll be able to combat any infectious diseases or other emerging or re-emerging that can come up in Africa or in the globe. Thank you very much, Professor Yaro.
Yeah, thank you.
I am a medical doctor, we have a veterinary doctor, we have somebody that did environmental health, a environmental health scientist, and different other professionals coming together, looking at the intervention of Mpox in their own perspective and bringing it to the table and asking government to fund them and ensuring that they sit at at the driver's seat and ensuring that they drive this to ensure that there is intervention at all levels. A doctor cannot do it alone. Animal sector cannot do it alone, and environmental scientists cannot do it. So we need to collaborate. In NCDC, in Nigeria, NCDC is the focal point for World Health, and our Director General is the chair for that World Health, and we meet regularly to look at the emerging diseases. And we know that more than 60% of the diseases emerging now, they are of animal origin. So we need our veterinary colleague to be able to unravel. They will be able to know where all these animals are coming from. How can we de-ratify them? How can we stop them? How can we stop the transmission through them? Well, what are the techniques we need to take, for us to be able to get to that level? And awareness is equally, one of the major things, despite the fact that people, the way people react, we need to still go ahead to do a awareness campaign all over, not only the special group, not only the immunocompressed group or pregnant women that are immunocompromised. We need to bring everybody together. We need to make awareness to be all over the country, and then we work, on the intervention strategy. Thank you very much.
Yeah, thank you. Professor Ashok, any input, any addition?
I think these kind of outbreaks are going to occur again and again.
Again, yeah.
So we need to have an immediate response, but also a medium-term and long-term response. And normally we should not depend upon the governments which have their own agendas to. So it is the society which need to have the collaborations. And in India, you would find that it's the private enterprise which runs the factories for vaccine production or makes the drugs. So I think is the what we need to invest and what you need to promote is that good students are sent for learning the latest technology with the promise that they will come back and work in their own countries. So that scholarship, whether it is in-service training, or whether you select the best students, send them out for training with the promise that they'll come back, then it should be possible to start making your vaccines locally, start making your drugs locally, and then be self-sufficient in the long term. So there should be long-term policies, there should be medium-term policies, and of course, we must respond to the immediate needs of the society.
Yeah, I think that's a good input. Sending people out to train and coming back to their various countries is very, very, very essential, very important, because most of the guys who go outside to train, when they finish, they prefer to stay. So I think that's a good suggestion that maybe all of us will put our heads together and, pressurize government here and there and see how best we can, solve this problem. So, Prof Ashok, maybe I would like you to take this question. Since COVID-19, the WHO and other associated organizations have started looking for the next virus or pathogen that has the potential of causing the next pandemic. I think they name it disease X. So when we look at Mpox, does Mpox have the characteristics to cause a pandemic?
No, I don't think so.
Okay.
I think it is limited. It will be a pandemic in the sense that it will be in many countries because it is of the way, as I said, our diagnosis is once it becomes infectious. If we diagnose when it becomes infectious, we'll not be able to control it completely. But since it spreads through, it's not as infectious as smallpox. It is not as infectious as COVID. It doesn't have the potential to be a pandemic, which we need to be scared of. But of course, see, biology is changing. It appeared in Science, there was a paper which indicated that the virus has genes which interact with the interferon gamma and tries to, so there's immune escape.
Okay.
Then there are genes in human beings which modify the virus so that one B has 42 changes from 2B. So that means it is encouraging the human genes are encouraging the virus to mutate at a faster rate. So prediction can always be very risky. And if it becomes highly infectious like smallpox, then you know how dangerous smallpox was. So we need to be vigilant. At the same time, I don't think monkeypox or Mpox would be able to meet the definition of a real species-ending virus.
Okay. I think that's very interesting, because I remember I read a paper on HHV6 that has the human herpes virus 6 that has the potential of integrating into human chromosome, which then lead to a number of diseases like cancer, neurological manifestation here and there. So if Mpox also has a potential of, I don't know whether it will have the potential of integrating in any of the chromosome. If it does, then we are, looking at a situation where we will start having inherited Mpox, maybe in future, not now. But I think it's something that we can also have a look later. Before I run up, there's a specific question that a friend sent to me when she heard that we are having this program on Mpox. She said, my question is, if there are already existing preventive strategies to prevent this pandemic, well, she has already even named it pandemic, why have they not done anything to implement them? Then the second question was, why the delay in implementation? I promised her that I'll ask the question, so I'm fulfilling my part of the promise.
Okay. Do you want me to answer it? I should go ahead?
Yeah, you can go ahead, yeah.
Okay. Actually, at the end of COVID-19 pandemic, there was a post-COVID-19 about what COVID-19 is all about, the pandemic, the lesson learned, and so on and so forth. So at the end of the day, we now sat together to draw up like a plan. So that, okay, for us to prevent the outbreak or to know and understand what the next outbreak would be, these are the ways we needed to do it. So the reason why it has not been done was because we need huge amount of money to actually start the implementation. And the point was that immediately we were able to conquer COVID-19, many people went and slept off. They went to sleep.
Yeah.
So they don't want to think about anything again until when this Mpox is now coming up. People now started running hater-scatter. It shouldn't be. There's supposed to be a readiness. There's supposed to be preparedness for any eventuality, for any threat. And that is the reason why in the NCDC we talk about protect, prevent, early diagnosis, then response, and then rehabilitation. So in NCDC, we just launched a 5-year strategic goals on all these 4 pillars, but we still need funding. Although Professor Ashok was saying that we don't need to put everything under government. Society is supposed to come in, but the society will tell you that is part of government work. Government is supposed to make everybody healthy. They have done their own parts. They have paid their own. They have paid their own tax. So, but NCDC now went ahead and they formulate what we call private public partnership. We bring in all these big organizations like a Dangote Foundation, so that if we have any of this eventuality, we can contact them and they can actually bring some funds. You remember during COVID, during Ebola in 2014, when before government brought out the money for the intervention, Dangote Foundation gave us 52 million, and that one was very much like billions of naira because we were able to do some certain things and we were able to support all this transmission. So before government brought out its money, we were able to use it. So that's the reason why we now say, okay, let us have a private public partnership where we can bring in Lumelu Foundation, Dangote Foundation, and other foundations that are interested in health of the people around them. So that's exactly what we're doing now, so that we can have fund like a basket fund that anytime there's going to be any outbreak, we can quickly dip our hand into it instead of waiting for government. And before government can release money, there's a lot of bottlenecks.
Bottleneck,
And the epidemic will not wait. People, while you are doing all your office work. So that is exactly what we want to do now. And then we believe that with this, we'll be able to combat the disease.
Yeah, thank you very much. Ashok, any input?
Yeah, to respond to your, when we respond, it depends upon access, availability, affordability, and acceptability. For example, if last year I would have said, I have smallpox vaccination, would you take it? You would say no, right?
Yeah.
So one is to have access. The second one is to have it available. The third is to have it affordable. And the third is acceptable. So only when the things are right and the risk benefit, the benefit overweighs the risk, you would then take a step. So at this moment, as you know, 10,000 doses have been gifted. More are coming from Japan. So they would, as WHO said, in 6 months' time, they have $131 million and they would supply 2 million doses. So now it will be used and this will contain. You see how seriously this has been neglected is that we still do not know. We say it's a zoonotic disease. We did call it monkeypox, but monkeys themselves are sufferers rather than the reservoir of this disease. So we still do not know what is the reservoir of the disease. So at this moment, that would mean that we need to work together, and there are so many questions, so many gaps that need to be filled. And we cannot take all precautions before they become due. So I guess a person who asked you the provocative question was is that, you know, it's like you're playing an orchestra, and when the time is right, would different actions be taken?
Okay, thank you both, Professor Ashok and Dr. John. I think on the basis of what we've discussed, I think it would be nice if in 6 months' time we come back and analyze what will have been the response. Was the WHO, did they, you know, manage to raise that 135 million towards monkeypox? And I think, as Professor Ashok said, there are a lot of gaps, knowledge gaps that we still have to, you know, fill in. So before I allow you to go, let's see what is the concluding remark, Dr. John.
Okay, thank you very much. What I really want to say is that we need awareness at every level. We can start from the federal level to the states, to the local government, and to the community. The community itself is the one that actually needed this awareness. If the whole community is aware of what is going on and they know exactly what they should do, you know, there will be interruption of the spread, you know, and people will know exactly what to do. They will be able to isolate their contacts. They will be able to take their cases to the nearest hospital where they will have treatment. And from there, monkeypox will be a thing of the past. Thank you.
Thank you, Professor Ashok.
I think Dr. John said it very rightly, that if people are aware of the risk and how it's transmitted, and then follow the suggestions which authorities have been saying, it will be controlled and there will be no transmission.
Well, on this note, I think we will end today's one-on-one. But before we end, I think the take-home message are, one, Mpox does not have the potential or does not have the characteristic to cause a pandemic. And secondly, we need to create massive awareness so that the populace will understand the transmission dynamics of the virus. Then thirdly, we need to wrap up or scale up collaborations. On this, I have to be partial and say AHRO is working so hard on a number of partnerships. And we very much like to work with the Nigeria CDC and Professor Ashok's company. So on this note, I want to thank all you for your time. And before I go, Dr. John lost his mom, so we extend our condolence to you.
So thank you very much, sir.
Yeah, thank you very much. So in the next session, I'll be in one-on-one. I will also be speaking with Professor Ashok, where we'll be talking about chikungunya virus. And I think I have to bring back Dr. John for another topic for us to discuss. Thank you very much.
Thank you very much.
Thank you very much.
Prof, thank you very much.
Thank you. It's a pleasure being with you.
Through Professor Yaro.
Thanks.
Okay, bye.
Bye. Thank you.
Yes.